Welcome everyone to the simultaneous session number 2, sickle cell disease care and a comparative analysis of sickle cell disease health practices in Canada and Lebanon. I am very pleased to welcome Dr. Adlet Inati and Dr. Kevin Kuo. Dr. Kuo will be joining us shortly, and it's my pleasure to introduce Dr. Inati. So Dr. Adlet Inati has a mission to spread awareness about preventive and early detection measures for catastrophic blood disorders. She has conducted a national newborn screening campaign for inherited hemoglobin disorders, identified the exact prevalence of these disorders, and enrolled affected children in a free comprehensive treatment program. In 2006, following the death of her son in a car accident, she established the George Nazem Kuriati Foundation, which has offered free medical care to 1,000 children with cancer and blood disorders to 10,000 people through its dispensary. She also founded GNK Traffic Academy, which teaches Lebanese students ethics and rules of safe driving. She mentors junior Lebanese physicians and medical students, residents, and fellows to become not only expert doctors, but merciful healers. And we're very fortunate to have her speaking with us today. Dr. Inati.
Thank you, Dr. Brian, for your kind introduction. Thank you, my dear friend Larry, for inviting me and for the organizers as well. I shall be addressing sickle cell care in children. This is my disclaimer. And these are the topics I will cover briefly: review sickle cell disease pathophysiology, go through major disease complications in children, then cover standard of care in children, briefly review curative and novel therapeutic modalities, and then review the ASH 2020 sickle cell disease guidelines. As you're all aware, sickle cell disease is an inherited lifelong blood disorder characterized by chronic hemolytic anemia, vaso-occlusion, or blockage of small blood vessels and end organ damage. It's clinically heterogeneous and associated with significant morbidity and mortality, reaching 8% in first 5 years of life in low-resource countries like sub-Saharan Africa. And due to migration, it is becoming a global disease. It is a monogenic disorder due to a single mutation, which leads to a single amino acid substitution in the beta-globin chain. That leads to the formation of hemoglobin F monomer, which under conditions of deoxygenation will lead to the formation of the sickle-shaped red cell, which dies prematurely, leading to hemolytic anemia, and blocks or occlude small blood vessels, leading to vaso-occlusion. Both vaso-occlusion and hemolytic anemia do result in a lot of downstream effects manifested as pain, vaso-occlusive crisis, organ damage, and fatigue. And the more we know about the disease, the more we understand it is not a blood disorder. It's systemic vascular disease. And the complications of this disease begin in early childhood, are lifelong, and can be acute and chronic, affecting every single organ, from the brain, to the eye, to the ears, to the heart and lungs, the gallbladder and liver, the kidneys, the penis, the spleen, joints, and bones. But the hallmark of the disease remains the vaso-occlusive crisis, which are one of the most common complications, and every child with sickle cell disease will experience one VOC at least once in his life. It's an inflammatory disease, and this is a trigger where the inflammation, cell activation, and upregulation of adhesion molecules like Sickle. This leads to multicellular adhesion, involving not only red cells, as you see, white cells, platelets, endothelial cells, and leading to vaso-occlusion, and if not treated, and recurrent tissue and organ damage. It's a multifactorial pathophysiology. But what we see in the clinic, which are these painful crises that are basically very unpredictable, very severe, is just the tip of the iceberg. What we would like to prevent is that subclinical vaso-occlusion, which ultimately returns it's not and organ damage and a lot of complications and decreased survival. And pain is the most common complication of the disease, beginning in early childhood and across lifetime. It is the first cause of healthcare utilization, associated with significant morbidity and profoundly negative impact on patients' health-related quality of life. As I mentioned earlier, it's typically very acute. The Africans describe it as like a drill in their bone, severe, involving any body organ. And with a high recurrence rate and with the inflammatory pattern of the disease, serious complications and end organ damage will undoubtedly happen if no therapeutic intervention is in place. Acute pain is defined by pain that results in an unplanned visit to an acute care setting for treatment, while chronic pain, which is not common in children, typically in mostly adults and elderly, is ongoing pain on most days of the past 6 months in single or multiple locations. And there are so many triggers: hypoxia, cold exposure, stress, infections. And the two most commonest causes of death in early childhood are infections and acute SNAG sequestration. Infections mostly due to SNAG dysfunction. Encapsulated organisms are usually the common organisms: Haemophilus influenza, meningococcus, and pneumococcus. That can lead in sudden death. Frequency and mortality, fortunately, have been significantly decreased by newborn diagnosis, preventive therapy, and rapid access treatment and family education. As for acute SNAG sequestration, the spleen suddenly enlarges with a hemoglobin fall of at least 2 grams per deciliter. It can be seen up to 30% of children in the first years of life. And like infection, it can result in sudden shock and sudden death in hours. Very high recurrence rate, again, mortality increase with neonatal screening and parental education. When you see a child who has a sudden drop in hemoglobin, think of the 3 possibilities: acute SNAG sequestration, aplastic crisis, typically due to parvovirus B19, and hyperhemolytic crisis. These are medical imaging. And the second complication is acute chest syndrome, which is the second cause hospitalization. In children, as you see, it's like a pneumonia, that white patch compared to the air in the lungs here. It is, by definition, this infiltrate associated with respiratory symptoms. We see it in 1/3 of cases of pain. Associated mortality, fortunately, is lower in children compared to adults. However, it is associated with increased risk of chronic lung disease, respiratory failure, prolonged hospitalization, premature death, if recurrent and not attended to. And whenever we see a child with stroke is quite uncommon in children. Think of sickle cell disease, because that's a leading cause of death in this age group. Overt and silent stroke are seen in 11 and 22% of children by 18 years of age, a very high percentage. High recurrence rate. Fortunately, it's preventable and treatable. And the way to detect the risk for stroke is doing transcranial Doppler to measure the cerebral flow velocity. And if it's abnormal, like the pink here, the probability of that child of remaining stroke-free is very, very minimal compared to those with normal transcranial Doppler or conditions. So the message is abnormal transcranial Doppler means high risk of stroke. So from the most common complications I've mentioned in children, you can imagine care of children with sickle cell disease is complex and can best be done in comprehensive care setting, with specific goals to reduce symptoms, prevent and manage complications, improve quality of life, and first and foremost, prolong survival. The standard of care in sickle cell disease consists of comprehensive care, pain management, hydroxyurea, transfusions, and curative therapy. Consists mostly of stem cell transplant in children, very few trials on gene therapy in adolescents, and novel drug therapies that I'll talk about later. And in order to have a successful, optimal, comprehensive care program, there are key elements to ensure: early diagnosis followed by preventive care, screening for preventing and treating complications, partly neurologic, education of patients and caregivers on symptoms and signs of life-threatening these complications, and very important and very neglected often, a coordinated, interdisciplinary, patient-centered, and friendly setting. Dr. Chinsky has taught for more than 30 years now, very beautifully, that babies with sickle cell disease or diagnosis with enjoy a significantly higher survival compared to those diagnosed after the newborn period. And the goal of newborn screening is to prevent and minimize sickle cell complications. Well, one of those Preventive modalities is prevention of infection through offering prophylactic oral penicillin from 4 months to 5 years of age at least, and providing routine childhood vaccines against encapsulated organisms, as well as yearly influenza vaccine. And coming to cerebrovascular disease in children, I just summarize the new past 2020 guidelines regarding this. I mentioned earlier that it's important to do transcranial Doppler on every child aged to 16 years. And for those who have abnormal results and living in high-income setting, regular blood transfusion for at least a year can be given. If after 1 year and having no vasculopathy and no silent trigger infarction, hydroxyurea at maximum tolerated dose can be given. As for low middle-income settings, hydroxyurea at least 20 milligrams per kilo per day at a fixed dose or at maximum tolerated dose is the reasonable option. But for somebody with a stroke, the only treatment to prevent further stroke and to treat stroke is chronic blood transfusion. And the recommendations is for every child, once at least in early school years, a one-time MRI, brain MRI, needs to be done to rule out silent cerebral infarction. What about acute pain? This is the commonest reason for referral to the ED. It's mostly supported. There's a combination of ASH 2020 guidelines and National Health Lung Blood Institute Expert Panel Report 2014, which are basically similar and really focus on the following: assess pain and give analgesia in 30 minutes at most. Reassess pain every 15 minutes to optimize pain control. Give an ascending pattern of analgesia, starting with mild ones, moving to the parenteral opioids, and once pain is under control, gradually titrate these opioids. Can give, for selected cases, ketamine and regional anesthesia. It's also helpful to use oxygen hydration in central spirometry. And it's important to emphasize that these patients can be treated only in sickle cell disease dedicated hospital-based acute care facilities and not in regular ED. And always anticipate and treat complications. But I'd like to really focus one important issue, and this is use an individualized patient-centered interdisciplinary pain approach. Every child behaves differently. Believe your patients, and this is for the emergency room doctors. Avoid considering them opioid seekers and guide treatment with their pain severity. And for more than 20 years, hydroxyurea, the first FDA-approved sickle cell disease modifying treatment, has been shown to be effective with multiple benefits in randomized controlled trials across all age groups, from baby hug to the adult studies. Hydroxyurea really, if we want to summarize, increase hemoglobin S, improves hematologic parameters, so it really improves oxygen delivery to tissues. It reduces complications from VOC, hospitalizations, transfusions, even the TCDs, and it's recommended to be started at 9 months. Sadly, however, globally, it's often underprescribed and underdosed. Very few unmet needs with hydroxyurea. I would assume they're not that major, but we need to be aware of them. Low blood counts, usually transient, suboptimal response, and a few patients and caregivers who are unwilling to use it. What about transfusions? Let me start by highlighting that different from thalassemia, transfusion-dependent thalassemia, in sickle cell disease, transfusions are given for selected group of patients only, even though they increase oxygen carrier capacity, prevent VOC, and reduce sickle erythropoiesis, but we have to really weigh the risks and the benefits. The only evidence-based indication for giving long-term chronic transfusion is treatment and prevention of stroke. As for simple transfusion indications, it's 2 categories: acute treatment of acute complications and preoperative only major procedures. It is not indicated for raising baseline hemoglobin, something that's really being done in so many parts of the world. Uncomplicated pain and minor surgeries. It could be given as simple or via exchange transfusion, red cell exchange transfusion. And for anybody on chronic transfusion, the recommendation is to give automated red cell exchange. So from what I've told you, blood transfusion and sickle cell disease are clearly effective in management of acute and chronic complications, but they are associated with so many adverse effects, the most feared of which is atomization and the resulting hemolytic transfusion reactions and iron overload. Alloimmunization means antibody formation against the transfused red cells. The red cell membrane carries so many antigens, hundreds of antigens, that can be different from one person to the other. It is an unrecognized transfusion complication. How to reduce it is important to know. Before first transfusion, recommendation is to give to extended red cell antigen profile, meaning not only ABO and RH, but the other phenotypes. And for patients receiving transfusions, give prophylactic red cell antigen matching for the ABO, RH, and K antigen. Many of the times we can do only this, and that can do, and avoid unnecessary transfusion and seeking care in multiple medical centers. The only curative modality for sickle cell disease remains hematopoietic stem cell transplant, which is associated with high overall survival and event-free survival, reaching 90s to mid-90s, especially with a full matched stem donor transplant. It is given for selected patients and preferably at a young age before organ damage was ensured. Stroke or high risk of stroke, recurrent refractory pain, acute chest syndrome, and early immunization. It does have limitation. Low availability of massive donors, risk of morbidity and mortality of transplant, and high cost. What I've told you, and historically it has been shown that with newborn screening and disease preventive and modifying therapies, including all of those, pediatric mortality has almost disappeared. If you compare that cohort, the older cohort, the MICAN cohort, that has not benefited from all these disease-modifying therapies, and compare them to the modern Dallas and London cohort, you can see the difference in fraction survival. With the projected survival in these groups reaching around 95%. But despite improved survival, sickle cell disease-associated childhood morbidity continues. And there's higher mortality seen in children not treated in astrocytosis and sub-Saharan Africa. And the rate of mortality is nowadays shifting closer to those in pediatric adult condition and adults. With a different pathophysiologic process in sickle cell disease, there has been a lot of interest in clinical research, and novel drugs have been recently approved by FDA. 2 for reducing pain, one of them approved for those about 16 years and given parenterally, that's crizanlizumab. Another approved for those above 5 years, given orally, it reduces pain, and that's called L-glutamine. And the third, increased hemoglobin, approved for 12 years and above of age, given oral at voxelotor. And the key 50 drugs are now in the pipeline undergoing clinical trials. Despite all the advances in sickle cell disease care, but many challenges still remain, and I know many of those have been addressed beautifully in this meeting. Some of them, definitely not all of them, are reducing morbidity and mortality in pediatric adult transition, minimizing childhood morbidity, preventing immunization, enhancing awareness of social human rights and mental health issues, ensuring equitable global free comprehensive care. And in conclusion, sickle cell disease is a systemic disease with multiple complications, often starting in childhood. Care of children with sickle cell disease, as I've shown, is complex, entails a patient-centered, and I hope all healthcare providers remember that patient-centered, interdisciplinary multimodality therapy with early prevention and treatment of complications. With early diagnosis and modern therapy, survival of children has significantly improved. And the last message I'd like to emphasize, do not forget the efficacy of hydroxyurea and transfusions. Novel agents must be widely used in combination with other effective therapies. Thank you for your attention.
Thank you so much, Dr. Anati. Lots of food for thought in your talk. I would like to, at this point, introduce our moderator for the remainder of this session. That's Dr. Melanie Kirby-Allen. Dr. Kirby is an academic clinician in the Division of Hematology and Oncology at Sick Kids Hospital. She is an associate professor of pediatrics at the University of Toronto and received her MD degree from the University of the West Indies. She completed her pediatric hematology and oncology training at the Hospital for Sick Children and the University of Toronto. She's the co-director of the hemoglobinopathy program in the Division of Hematology and Oncology at Sick Kids. She served for many years on the advisory board and moved to the governance board of SCAGO in 2017 and provides medical oversight for the organization. So Dr. Kirby, I'll hand things over to you.
Thank you very much. And I apologize for not being on getting things ready. I'd like to introduce our next speaker, who's Dr. Kevin Ko. And Dr. Kevin Ko is one of our colleagues. He's an adult hematologist and clinician investigator in the Red Cell program at Toronto General Hospital University Health Network. He's an associate professor in the Division of Hematology and an assistant professor at the Institute for Health Policy Management and Evaluation through the University of Toronto. His clinical focus is on rare congenital hemolytic anemias, and his research focus on genetic modifiers and novel therapies in rare congenital hemolytic anemias like sickle cell disease, the impact of white matter changes on neurocognitive outcomes in sickle cell disease, and non-chelating strategies in the management of iron overload. Thank you, and we'll move to Dr. Ko.
Good morning, Dr. Kirby. Thank you very much for the generous introduction, and good afternoon to you, Professor Inati. It's always very difficult to follow the acts of Professor Inati as she gives such wonderful presentations. But what I would do today, though, is to provide you with a Canadian perspective of sickle cell disease care, building on the backbone of Professor Inati's talk. I hope all of you can see my presentation now.
Yes.
These are my conflict of interest disclosures. Today, my objective will be to discuss the epidemiology of sickle cell disease in Canada, newborn screening in Canada, talk about transnodal Doppler, hydroxyurea and transfusions, novel disease-modifying therapies, potential curative therapies in Canada, as well as the challenges and future directions within Canada's perspective. I must emphasize that because I am an adult sickle cell provider, that mostly I will be speaking from the lens of an adult hematologist, as opposed to Professor Inati, who is a pediatric hematologist. So let's start with the epidemiology of sickle cell disease. We think that in Canada, we have approximately 5,000 patients, or 13 per 100,000 Canadians. And this number varies, as you can see, between provinces. The three largest provinces, which where we mostly find sickle cell disease, are in Ontario, Quebec, British Columbia, and most recently in Alberta as well. And you can see that the birth rate is quite variable between these provinces. Unfortunately, the data accuracy is limited by a lack of national registry. However, we are actively working on one, and we're hoping that we will have one day with the support of both the government as well as other non-governmental organizations. You can see here on the right-hand side where the hearts are places where we have comprehensive sickle cell care in Canada. As most patients with sickle cell disease live within one of these comprehensive care center, I must say that we are able to provide majority of coverage to majority of the Canadians with sickle cell disease. It is indeed, as we say in Canada, the model of Canada being mare usque mare, from sea to sea. And you can see here from, all the way from Vancouver to Halifax that we're able to provide such comprehensive care. And we based our model of comprehensive care on these guidelines. So we have a consensus statement on the care of patients with sickle cell disease in Canada. This was published in 2016, and more recently, we will be coming up with a revised guideline. And in addition, of course, we have our patient organizations. We have the Sickle Cell Disease Association in Canada, with a number of the being the umbrella organization of the provincial organizations such as SCAGO and SCALE. as well as a CAN-HEME, which is a Canadian Hemoglobinopathy Association. This is the association of various sickle cell providers that provides a forum for us to interact and to exchange our experiences, as well as to promote research, education, and nursing care. In terms of newborn screening, this is a very typical way in which we perform newborn screening. So we typically obtain the blood from a heel prick test on the Guthrie card, which is essentially a paper absorbent card in Canada, and then we then will take that and put it through a machine called a high performance liquid chromatography, or HPLC. Of course, babies with hemoglobinopathy, such as sickle cell disease, even when they're born, they don't have sickle cell disease, and at least not until 4 to 6 months of age. And the reason is because the red cells are mostly filled with a hemoglobin called fetal hemoglobin, or the baby hemoglobin. And of course, this protects them from the ravages of sickle cell disease. And as a result, the initial screen needs to be interpreted very carefully. If there is abnormality, then the family will be contacted, which then consent will be obtained. And you're going to ask, well, why do we need a two-step testing? And the reason is because if someone has a lot of fetal hemoglobin, even though there may be some sickle cell hemoglobin inside the red cells, this does not necessarily mean that the patient has sickle cell disease. Often the patient may have trait or may have other forms of sickle cell disease, and it is not possible to distinguish until we have a confirmatory testing. And this is why we do a two-step process. And in the second step, we do contact the family. We ask for consent. If the family declines, then we don't take any further action. However, if the family consents to this confirmatory testing, then they'll go through the confirmatory testing. And if the result is positive, of course, the patient will be referred to the newborn screening team, which then accompanies the patients and the parents to their first clinic visit at the pediatric hospital. You can see here that newborn screening has really changed in Canada. In 2013, we only have a in green, Yukon territories, BC, Ontario, and sickle cell patients. You can see that screening was still quite limited and not implemented. However, today in Canada, I'm proud to say that majority of the provinces and territories offer newborn screening, as you can see here. In terms of transcranial Doppler screening, we've followed the guideline of annual TCD screening starting at 2 years of age, and patients who have abnormal TCD screenings will repeat within 2 weeks and initiated on chronic transfusions. And where chronic transfusions are not feasible, for example, if they have alloimmunized because of previous transfusions, alternatives like hydroxyurea will be considered. Patients who have so-called conditional TCD velocities will be screened every 3 to 6 months. Of course, at this time, we're still uncertain as to what we can do for these patients as they lie within the conditional territory. Often, many of these patients with other complications from sickle cell disease, such that we'll be starting them on hydroxyurea or other disease-modifying therapies. In terms of primary stroke prevention, patients are placed on chronic transfusions, but then are subsequently transitioned to hydroxyurea, at least in those patients who don't have an overt stroke, TIA, or vasculopathy. Hydroxyurea remains the backbone of treatment in patients with sickle cell disease in Canada. Patients with at least one complication due to sickle cell disease are offered. I can speak to our clinic's practice in Toronto and in the adult clinic is that we titrate to the maximum tolerated dose, and this is also the case in other centers in Canada. And different centers have different definitions of maximum tolerated dose, but at our center we defined it as a reticulocyte production index between 0.8 and 1.2, and an absolute neutrophil count between 1,000 to 2,000. Or 1 to 2 in Canadian units. Approximately 40% of our patients at our center are on hydroxyurea, which is very typical across Canada and other parts of the world as well. And the mean fetal hemoglobin while on hydroxyurea at our center is around 29%. which demonstrates that, when hydroxyurea is taken, it still remains an effective approach at preventing complications or slowing down the progression of complications in sickle cell disease. You can see here that similar to what Professor Inati has presented with the survival curves, that indeed the survival at our hospital and many places in Canada is increasing with improved treatment. Currently, as Professor Inati pointed out, that hydroxyurea, L-glutamine, voxelotor, and crizanlizumab are approved by the FDA. However, in other jurisdictions, including Canada, many of these therapies are not yet approved, and I will go into a sort of briefly reason why. You can see here that L-glutamine and Endari was withdrawn and refused actually by the EMA. It was voxelotor and crizanlizumab are approved by the EMA. The UK MHRA also refused L-glutamine's review. Voxelotor is currently under review, and crizanlizumab is approved. And in Health Canada, only hydroxyurea is approved. And the reason is because none of the other companies that makes Endari, Oxbryta, or Adavio have filed for approval. The onus for approving a drug rests with the drug companies that has to file the application. So let's start with some issues that I see in these newer therapies. With the L-glutamine, while the reported outcome is that there is fewer pain crises, 36% of patients on L-glutamine dropped out of the study, and this is mainly due to the gastrointestinal side effects. And the FDA, the Food and Drug Administration in the US, noted tremendous bias in the method of imputation, imputation is a way for us to guess. If someone has dropped out of the study, then of course we don't have data on it, but sometimes we do a statistical testing called imputation, which we guess what they would look like if they had remained on the study. But the FDA noticed significant bias in which this imputation was carried out by the producers of Endari. And the repeat analysis actually showed a much smaller effect size. So the EMA, based on this data as well, refused marketing authorization in May of 2019. In terms of voxelotor, all the published results focus on laboratory outcomes like red cell physiology, rheology, and hemolytic parameters. And only 2 abstracts by Professor Vinchinsky has mentioned about vaso-occlusive episodes as an outcome. And unfortunately, there was no reduction in vaso-occlusion episodes compared to placebo. However, there was a trend towards a reduction in cumulative incidence of VOC. That was stratified by hemoglobin value, but again, there was no significance value provided. Lastly, with crizanlizumab, although it did show a significant reduction in pain crises because of the way that crizanlizumab was manufactured, the FDA actually requested that the drug companies repeat many of the studies, including the phase 3 trials, because of this change. Now, what about, so now that we see that there's limitations in terms of the novel disease-modifying therapies, what are we doing in Canada in terms of our participation in international trials? You can see here from a relatively messy slide showing the mechanism of sickle cell here that in the gray are some of the past and present drugs that has been investigated in sickle cell disease. In Canada, we're actively participating in the ones that are shaded in blue. And the ones that are shaded in orange are the ones that have previously participated. And this includes hydroxyurea, voxelotor, rivapentol, as well as crizanlizumab. In terms of availability of potentially curative therapies in Canada, allogeneic stem transplant remains the backbone of the potentially curative therapy. Match-related donor is currently the standard care in children as well as adults in 18 to 40 in Canada. And centers of active transplant programs include Vancouver, Calgary, which also serves Edmonton, Toronto, as well as Montreal. And in fact, Calgary is one of the leading centers of hematopoietic stem cell transplant in children and adults with sickle cell disease in the world. And this program is led by Professor Greg Gilcher. Unfortunately, because we require match-related donor, this is often limited by donor availability. So approximately only 10 to 15% of those who are eligible for stem cell transplant have a donor. And you can see here that the eligibility is relatively broad, but it includes a number of complications of people with sickle cell disease would potentially be eligible. But again, the limiting factor is that they cannot be too sick. Now, lastly, I'm just going to go quickly into gene therapy because there will be other sessions on this as well, but that we are also actively participating in gene therapy, and this includes different ways of doing a gene therapy. For example, one way is to insert the instructions to make hemoglobin gene into a virus shell, and that to be delivered to the stem cells. Another way is to disable certain genes that control the production of fetal hemoglobin so that we can help the body to make fetal hemoglobin again. And of course, the advantages of gene therapy over stem cell transplant is that you don't have graft rejection because you're using your own cells. There is no graft versus host disease, again, because you're using your own cells. You don't have any donor availability limitations because you're using your own cells. However, things like infertility, transplant-related malignancies, and complications based on a conditioning regimen. And of course, there's also disease-related complications as well. All of the many gene therapies that are listed here, you can see in this table and the next one. We are currently participating in the Vertex as well as the Editas gene therapy program. Both of these are CRISPR-based. And in the future, we'll be participating in the BioVeritiv, the zinc finger-based gene therapy approach as well. And of course, the question is, with all these many different therapies, are we dealing with one silver bullet that can strike sickle cell disease, or are we talking about multiple types? And then, of course, when to strike. And because of this question, we are also participating in an international collaboration searching for genetic modifiers in hemoglobinopathies through large-scale multi-ethnic genome-wide association studies so that we can locate newer therapeutic targets for sickle cell disease. And factors considered to treatment of sickle cell includes the following. Obviously, curative therapies are high risk and high reward, versus disease-modifying therapies that can control but not necessarily cure the sickle cell disease. There's limited inclusion criteria of many of these potentially curative therapies. Accessibility is also an issue. And then the question is, are we trading one disease complication for another? For example, the graft versus host disease or the therapy-related cancers. Clinical trials, of course, is very crucial to allow early access to these new therapies for our patients. And lastly, of course, even if these new therapies are approved by Health Canada, we still have to think about the arduous funding pathway for novel therapies in Canada. This includes a health technology assessment by an organization called CADTH. The PCPA, which is a Pan-Canadian Pharmaceutical Alliance, needs to negotiate for the price of the drug with the Canadian provinces. Even after that, the provinces, the provincial formularies needs to approve the funding of such drugs in order to get to the patient. So because to address this shortfall, Health Canada and the government of Canada has come up with building a national strategy for high-cost drugs for rare diseases. And I'm hoping that this national strategy will overcome a lot of the funding barriers that we have seen previously in disease-modifying therapies for sickle cell disease. And with this, I draw to a close, and I thank you for your attention today.
Thank you very much, Kevin, for that full overview, which was very informative. Before we go to Q&A, we may have time for one or two questions. We would like Dr. Brian has to review Dr. Anati's bio.
Yes, I wanted to express my sincerest apologies to Dr. Anati. There were some omissions made to her bio, and so I'd like to correct that now by ensuring that we include the correct information. So Dr. Adlet Inati is a professor of clinical medicine at the Lebanese American University Biblios. She's the head of pediatric hematology, oncology division, and director of comprehensive SCD program at Nini Hospital in Tripoli, Lebanon. She has a team providing comprehensive care to 1,000 people with catastrophic blood diseases and childhood cancer. She received her medical degree from the American University of Beirut and had her pediatric residency and hematology fellowship at Johns Hopkins Hospital and Boston Children's Hospital, Harvard Medical School. She's an American board certified and Alpha Omega Alpha Honor Medical Society member. She's published 85 publications in peer-reviewed journals and hundreds of abstracts in key hematology meetings and is a reviewer for leading international journals. She is principal investigator, advisory board, and steering committee member in multiple global trials evaluating novel agents in sickle cell disease. And again, my apologies, Dr. Inati. We certainly did not want to discount
No
any of
problem,
your many
Jennifer, you didn't
accomplishments
have to
there.
do it, no problem at all. No problem at all.
Thank you both again. Fascinating sessions this morning. Dr. Kirby, thank you so much for allowing me to interrupt. Please do continue.
Thank you. So I don't see any questions in the chat. As I'll ask the first one, Dr. Cole mentioned that he in the adult program with hydroxyurea, he starts after one VOC complication or one VOC episode. Dr. Nati, what is your usual policy in starting treatment plan? When do you start?
I think as Professor Kiyo and myself have alluded, hydroxyurea is an excellent drug and will remain an excellent drug. In our program, every child at 9 months of age is given hydroxyurea, regardless of the severity of the disease. Every child who comes to us, because we take care of both 60% children and around 40% adults, and are among the 400 people who take care of them. So whoever comes to us, even though he or she were not on hydroxyurea, regardless of the age, again, I'll say we start hydroxyurea, except if there's an absolute contraindication to do that. We believe in it, and we titrate it to the maximum tolerated dose. Actually, our protocol is exactly what Dr. Kevin has mentioned, except that sometimes we do not do a tick as frequently because of financial issues, but we do definitely the CBC and HPLC and follow the clinical parameter, all the clinical complications. And we have had, if you should listen to the patients what they say. I mean, they call it the wonder drug. We think hydroxyurea not only has been underutilized and underdosed, but we think also there has not been emphasis from healthcare providers on the rationale and the benefits of hydroxyurea, and the need to do it at maximum tolerated dose. Because I see many patients receiving hydroxyurea for years as 10 milligrams per kilo or 15 milligrams per kilo per day, at a time when had they been escalated to the right dose, they wouldn't have all these complications. So that's, I believe, and I'm sure Dr. Kevin agrees with me, this is a key message we'd like to convey regarding this. Hydroxyurea is going to be used and is there to stay, and will be used like part of a combination therapy, like in cancer, along with whatever novel drugs are coming.
One of the concerns from families is how long can a child going into adulthood, or how long can a person take hydroxyurea for? Have you found any issues with long-term use of hydroxyurea?
Would you like to start, Kevin, or would you like me to start?
Maybe you can start, Professor Inati, because you deal with children, and then
as long as we're children, to be honest, and we follow these children very carefully because, as I mentioned earlier, as was mentioned before, our patients receive free comprehensive care, and they are seen comprehensively every 2 to 4 months and more frequently if needed. And we take very thorough history of them. We have had few incidents of transient myelosuppression. And in our criteria for stopping or decreasing hydroxyurea is an absolute neutrophil count of 1,000. I'll tell you why, and platelets 80,000. We need to remember we're dealing with children. Children are prone to a lot of viral infections, and viral infections can drop their counts very easily. So it can be transient, but we follow them very carefully. So we basically have had few episodes, but we did not have to stop any any patient from hydroxyurea, except for some patient who really was very worried about infertility, even though we provided the data, but he was very worried. Of course, we stopped it during pregnancy and during lactation, all of these, but we have never had encounters. So all what you hear about unmet needs, they are very, very transient. If you use it well, you monitor these patients well, you educate families, I think we'll see much, much better results on minimizing complications and overall survival, which would be nice to have a longitudinal prospective study on, the baby hug trial, let's say, or to see what has happened to this cohort of patients using hydroxyurea. That would give the data we'd like to hear.
And Dr. Cole?
I completely agree, Professor Inati. And in that when patients are transitioned from the pediatric clinic to adult, and when they remain on hydroxyurea, they are doing extremely well. And I must say that they do much better than, say, patients who start hydroxyurea as an adult, simply because many of the complications have been prevented. One thing I do notice is that even after 18, the hydroxyurea dose still requires some adjustment because of increased body weight and increased growth. That's something that we have to keep in mind. Many patients often say, "Oh, I'm an adult now. Hydroxyurea has worked for me throughout my pediatric years, but then now it seems to be losing its effect." And many times it turns out that, these patients are actually not on the optimized dose, the maximum tolerated dose, because they continue to grow, they continue to build muscle mass and so forth. Another point, of course, that you've mentioned, of course, is fertility concerns. Certainly in women, we do stop it during pregnancy. We advise women to do that because there is evidence to show that, the hydroxyurea should not be taken during pregnancy. However, pre-pregnancy use of hydroxyurea is certainly encouraged. And also with regard to male infertility, we know that at baseline, many patients, unfortunately, with sickle cell disease already have a reduction in sperm count. And this is often a large confounder when it comes to the use of hydroxyurea as well. So we as you said before, education and counseling is key with our patients. Nonetheless, in patients who do request it, we do provide sperm count for those who do.
And what you're alluding to, Dr. Kevin, is the fact that we have to weigh that the infertility issue and many of the complications are coming from the disease rather than the hydroxyurea. And the families and patients need to know that the risk of stopping hydroxyurea on the fear of infertility really is much higher than the risk of leaving the disease unattended to without hydroxyurea.
I completely agree with you. Unfortunately, the literature out there, I think, muddies the picture quite a bit because of the low quality nature of many of these publications.
Okay. Yeah. We have to stop now. This has been a wonderful session. Thank you, Dr. Inati. Thank you, Dr. Cole, and to the organizers, and thank you for the attendees. We will be coming back. The next session is at 12:05, and it's on curative treatments in sickle cell disease. I hope you all will join us at that point. Thank you very much.
Good seeing you, Kevin.
Thank you, Professor Inati. Thank you, Dr. Kirby.